Okay, we'll start. You can see this slide, right?
Yes, sir.
Okay. So I'm going to do Rh isoimmunization or rhesus isoimmunization. It's a very important lecture because you will get one question MCQ, 20 MCQs. One will be from and then in your clinics you will find in your clinical ward work you will find definitely you will find a case with Rh isoimmunizations. You will find a lot of cases, miscarriages, ectopic pregnancy, so on, so many types. So you will have to know how to tackle them. Right? So about Rh isoimmunization. So in 1939, this Stetson and Levine, they those two discovered this. The red cells can get agglutinized, right? So this red cell agglutination, this phenomenon was found in 1939, and in 1940, this very famous Weiner is a very famous hematologist. Him and Landsteiner, they discovered the Rh antigen, right? So they discovered Rh antigens. We found that antigen from that monkey. Then in 1953, a person called Bruce Chown actually found that Rh isoimmunization was due to passage of Rh negative passage of from fetal circulation to maternal circulation is the one that caused the Rh sensitization in the mother. And in 1945, this Coombe test was discovered, where you can check the agglutination of Rh antibodies, right? And then when we check we do a test called indirect Coombes in the circulation, and if that is positive, we say that the mother is sensitized, right? Anyway, these Rh antigens or rhesus antigens, there's a funny nomenclature. It was actually invented by two people called Fisher and Race. So three pairs of antigen are there: D, C, and E. D, there is simple D, capital D. C, there is simple C, capital C, and E, there is simple E and capital E. So the prominent gene D and the recessive gene is simple D. So there are about 45 Rh antigens, but D antigen is the major cause of Rh incompatibility. So not the other one. So major percent of lesser amount of indurations, that is us, express this D antigen, express the D antigen and so-called Rh negative. So, if you can understand more in whites, you can find Rh negative women than in us, the Asians, right? The D antigen and the anti-D has never been isolated, but it is included in the nomenclature for completeness. So the D antigen, we have not found it, but for the nomenclature, we need two Ds: capital D, simple D, capital C, simple C, capital E, simple E. So because of that, we normally put it in there, but it is not been isolated. Okay. So physiology, the pathophysiology of hemolytic disease of the newborn. What happens in this phenomenon called the hemolytic disease of the newborn? So here what happens is, okay. So what happens is, the paternally derived red blood cells, antigens, or that is foreign antigens, if the baby gets that antigen, the mother is not having that antigen if the mother is Rh negative. So if the father is Rh positive, the fetus can inherit that father's antigen to the baby. So when a volume of blood is leaked from maternal circulation to the from fetal circulation to the mother due to a breach in the placental barrier, then the maternal circulation will get some amount of fetal cells, and these fetal cells are lacking the D. These fetal cells are actually Rh positive, so they are they are immunogenic. They are having Rh positive, D antigen positive, and then the maternal circulation is Rh negative. So then my mother does not have the Rh antigen. So then what happens is this Rh positive red blood cells they will stimulate the white blood cells to produce antibodies against these Rh positive cells, and these antibodies is the one that will cause the immune reaction. So the D antigen, why is it so important? Is it is 50 times more immunogenic than the Rh antigen. So when baby's blood mixes with the mother's blood, there are so many other antigens coming, but the D antigen is 50 times more immunogenic. So because of that, even a small amount of blood is capable of mounting an immune reaction in the mother's circulation, and this antibody that is produced in the mother's circulation will have memory cells. So it will be in the mother's circulation as memory cells. Those white blood cells will be there throughout her life. So she is called a sensitized person. So what happens in the next pregnancies, when she gets sensitive, if she's a sensitized lady, with the next pregnancies, if there is another fetal-maternal, if the baby is again positive and the mother is negative, then these mother's antibodies can cross the fetal, the blood placental barrier and go to the baby, and this antibodies will go and bind to fetal cells in the fetal circulation, and that will cause a agglutination of red blood cells, right? So as we know, the primary exposure will only cause a IgM response, and these are pentamers and they cannot cross the placenta and go to the fetal circulation and cause agglutination of fetal cells. But if the subsequent pregnancy is also a positive baby, now second response is IgG, and this IgG of course are small antibodies, not pentamers, and they cross the barrier. They cross the placental barrier, and they will go to the fetal circulation, and there they can mount a cell aggregation response, and these aggregated red blood cells will be destroyed in the reticuloendothelial system, and that's what happens, and that will lead to fetal anemia in pregnancy. So it's important to understand that once a woman is sensitized with the D antigen, an Rh negative woman will be sensitized for life. That is because of the memory cells. So any subsequent pregnancy, there is a chance of Rhd antibodies crossing the placenta and going into fetal circulation and destroying that fetal red blood cells. So subsequent pregnancies, there's a risk of fetal anemia. So higher the number of pregnancy, the higher the chance that she can get babies with severe fetal anemia. So what are the features of severe fetal anemia? One thing is polyhydramnios. So and she is pregnant, Rh positive baby. We give me 1 minute. Dushan? No one in the lecture. I didn't have no time. So when we know, we follow them up with serial ultrasound scans. So what are the features we check? We check for features like polyhydramnios, fetal Dopplers and fetal middle cellularity Dopplers, right? And reduced fetal movements and CTG abnormalities like reduced variability and sinusoidal type pattern of CTG variability. I will discuss those things when you come to final. Things that anemia. Now we are worried about anemia severe phase. We can have a high risk of dying of that. So can we prevent this happening? The best thing is prevention. If it happens, then we have to treat, but best thing is to prevent it. So by giving anti-D immunoglobulin within 72 hours to the mother, we can prevent any red blood cells that has come into the maternal circulation, sensitizing the mother. So what we do is, as soon as the baby is delivered, we check, we give a dose of anti-D immunoglobulin. What this anti-D immunoglobulin does is, it will go and bind to the fetal cells which has crossed into the mother's circulation. When it binds to these fetal cells are anti-D positive, and these immunoglobulins will bind to D positive cells, and then D positive cells which are coated with these immunoglobulins will be destroyed in the maternal circulation, right? The thing is, how much should we give? So what we do is, roughly the routine recommendation is you give about 500 international units of anti-D if it is the delivery, or if the miscarriage is after 20 weeks. Before that, we give 250 international units, right? So in 500 international units is about 100 microliters of anti-D. But in Sri Lanka, we have vials of 1500. So we give the whole vial, we give, because I mean, these are glass vials. You can't reuse it. You can't put it in the fridge and reuse again. Once broken, it has to be used. So we give whole 1500. Whatever is needed will be used. Rest will be destroyed in our body. So if we are giving 1500, that is adequate for 30 ml of Rh positive blood, or 15 ml of fetal cells. So 15 milliliters of fetal cells can be antagonized by 1500 units of 1500 international units of anti-D immunoglobulin, right? So that is the postnatal prophylaxis. There's another thing called the antenatal prophylaxis. This antenatal prophylaxis is actually not practiced in Sri Lanka at the moment, because we don't have funding. Because we all know, at the time of delivery, of course, the placenta is removed by controlled contraction, and due to these things, there's a very high chance that fetal cells and maternal cells will be admixed. And that's why we routinely give postnatally 1500 international units to the mother. But what about small bleeds that can happen during antenatal period? Especially after 28 weeks, there's a high chance that there can be a risk of small amount of fetal-maternal bleed. Most of the time, this small amount of blood is not enough to sensitize a woman, right? But rarely it can happen. So in countries like England, they give 2 doses of anti-D 500 units at 28 weeks and 34 weeks. This is to cover this small amount of bleeding. Now, in Sri Lanka, we don't give it, not because anything else, only because it is a little bit expensive thing, and trying to give this much of amount of vials in whole island will cost a huge amount. So it's purely, you call it the number needed to treat. To prevent one case of future fetal death, you have to treat lot of women with this vials, and that is not cost effective when we are not earning that much, and when these things have to be imported for dollars, right? But still, so we routinely and universally we give postnatal anti-D prophylaxis. But still we find alloimmunization. Alloimmunization can this type of immunization where the fetus and the mother, the mother gets sensitized from the fetus. Now, why is that? Actually, it can happen at the time of birth of the baby, if we give that 1500 units even, still it might not be enough. Sometimes when we do therapeutic or spontaneous abortions, it can happen. Ectopic pregnancies, it can happen. Threatened miscarriages, it can happen. Clinical procedures like coronary villus sampling, amniocentesis, podocentesis, it can happen. External cephalic versions, if it is a negative mother and a positive baby, it can happen. Just any instance of fetal maternal bleed can give rise to alloimmunization, right? So it occurs due to failure of routine antenatal prophylaxis, or sometimes we might not identify event, right? We might not think that this event is a event that can cause a fetal maternal bleed. For example, a small accident. Sometimes there might be event of fetal maternal bleed due to placenta being damaged, but we might not recognize that. Maybe a fall. It also can cause this, right? Sometimes it might be in a very busy ward, we might forget to give the antibody. Now that is also a problem, right? So even if we now other thing is, in countries like Sri Lanka, we are not giving antenatal prophylaxis. We are giving only postnatal. So still there's a small chance that this antenatally also it can mix and cause sensitization. So even in the current regimen, we can still have a positive case reality. So about the Rh system, it is associated with severe hemolytic disease. Out of all antibodies, D is the most commonly associated with the severe hemolytic disease. As I told you, it's 50 times more. It's 50 times more antigenic. That's why. So only occur if the Rh mother is Rh negative and the baby is Rh positive. And anti-C and anti-E also can cause a hemolytic reaction, but it is less common in the community. So we might not see this type of disease, right? And there are other hemolytic diseases as well. So whenever you get a hemolytic disease of the newborn, don't think it is anti-D. It can be Kell, Duffy, Little E, and S. So these are other systems of nomenclature for different types of antibodies, alloimmunizations that can happen and give rise to fetal anemia. And then you have to know a little bit about the ABO hemolytic disease as well. Now, ABO hemolytic disease also is a hemolytic disease. This happens if the mother is, if the mother's blood group is O and the father's blood group is A or B. If the father's blood group is A or B and the mother's blood group is O, the baby can be A or B. So here, here what happens is what happens here is this ABO incompatibility happens when the baby's O antibodies, when the baby's blood group is A and the mother's blood group is O, this A crosses the maternal the placenta and crosses to the mother, and the mother can get sensitized. But here this type of sensitization does not need to happen. So inherently, as this A and B substances are there in food and bacteria. So as if we are O, we inherently we can have a A and B antibodies in our circulation if we are O. That is because we don't need a sensitization event to happen for us to develop the antibody reaction. Now, in Rh antibody isoimmunization, we all know the baby's blood has to cross the placenta and come to the mother for mother's blood to get sensitized. But this doesn't need to happen in ABO system. In A and B, because A and B substances are very commonly found in natural things that we see in the environment, like bacteria, maybe some food products, they also have these A and B particles, and that when we eat or when we come across these, get infected with this bacteria, we get sensitized if we are O. So it doesn't need to be the second pregnancy when there's ABO incompatibility. because even in the first pregnancy, if the baby is A and the mother is O, the O mother would have a antibody reaction in her circulation and will cross the placenta and go and damage the baby in that case, right? So if there's alloimmunization, what are we going to do? So if the mother's blood group is negative and has developed antibodies, it is important that the paternal blood group is known, because if we know this mother is sensitized, we know this mother has antibodies against Rh positive red blood cells. So then what we do is we check the father's blood group. If the father's blood group is positive, then he has two possibilities. He has DD or D simple D. Both will anyway present with positive blood group. If the father is capital D, there's a 100% chance that the baby is also positive, because mother will only give simple D. She is negative. If the father is simple D, capital D, there's a 50% chance that the fetus is positive. So if the father is capital D, we don't check the baby. If father is capital D, simple D, we have to do a amniocentesis, and or we can do NIFT, that is non-invasive perinatal testing, and we have to do the fetal blood typing, right? If we know the fetal blood type is positive, we will know that this baby can get affected because the mother is sensitized. If the mother is sensitized, what can we do? So if the mother is sensitized and we know the baby is positive, we know now this baby can get affected. So we can do two things to see whether this baby is getting anemic due to cross passage of antibodies and destruction of that baby's red blood cells. One thing we can do is the invasive testing. That's what we do is we take amniotic fluid every week or two, and we do a amniotic fluid spectrometry. So we take a little bit of amniotic fluid and we put it in this chart called the Lilly's chart, right? In pediatrics, they will teach you the Lilly's chart to check for serum hyperbilirubinemia. This Lilly chart, which was developed in 1961, this chart has three zones: mild hemolytic disease zone, moderate hemolytic disease zone, and severe hemolytic disease zone. So normally we check this, we take the amniotic fluid and we check the optical density in 450 nanometer of bilirubin in amniotic fluid. How much? This optical density 450 nanomillimeter is there, and then we plot it in that graph. If this optical density of 450 is high, there's a severe chance. That means there is high level of bilirubin. If it is moderate, there's moderate amount of bilirubin. It is mild amount of bilirubin, right? So that is for amniotic fluid spectrometry. And if we think that the baby is going from low zone to a high zone, we know this baby's red blood cells are getting destroyed and bilirubin concentration is increasing. That will only cause brain damage in the baby. So if it is crossing lines, we know this baby is getting affected and we will have to deliver this child. Then we have this thing called non-invasive testing of hemolytic disease of the newborn. Here what we check is we try to check fetal anemia by checking the middle cerebral artery Doppler. Right? We call it MCA Doppler. Normally, if the baby is having anemia, the MCA Doppler velocity increases, right? So a very important study done by a person called Mary, so we call it the Mary eta actually. She only found out that at peak systolic velocity of more than 1.5 multiples of median කියන්නේ normal එකකට 1.5කට වඩා වැඩි වගේ. If that value comes as more than 1.5, it is not a value that you have to memorize. It will be given by the computer. Only the cutoff you have to memorize. More than 1.5. You do a Doppler and you press the PS how much is the PSW, PSV, it will tell 1.3, 1.5, 1.7, whatever. So if it is more than 1.5, there's a high chance that the baby has fetal anemia. So that is called non-invasive checking of fetal eye drops. So once we suspect that there's fetal anemia, now then what we have to do is, now we have to confirm that the baby is having severe fetal anemia, because these are tests that are surrogates. That means we don't check the fetal blood. But once we suspect that there's fetal anemia, we have to check the fetal blood. For that, we do a thing called PUBS. PUBS is percutaneous umbilical cord sampling. We put a needle through the tummy towards the baby's umbilical cord. We give a anesthetic medicine to the umbilical cord, and the baby will be anesthetized, and the baby will be not moving after that. And then we'll take some blood and check the amount of hemoglobin in that baby. And if we want, we can transfuse blood to the baby through the umbilical cord, right? So after 18 weeks, we can do this. And then what we do is, if the baby is anemic, from real-time testing, we can transfuse blood to the baby. So we call it codocentesis or intrauterine transfusion. So we put a needle, we go to the umbilical artery, and we take some blood, we check the hemoglobin level. If it is very low, we give O negative CMV, cytomegalovirus negative, washed and irradiated packed cells, and that is cross-matched against the maternal blood. This blood is transfused to the baby. So that is what we do, and so the baby can be, we can maintain the pregnancy a little bit more. This is done if the baby is too small to deliver. If we suspect fetal anemia by Lilly's chart or the middle cerebral artery Doppler, and the baby is mature enough, like 28 weeks, 32 weeks, we can deliver. I am telling, if the baby is only 22 weeks, 24 weeks, and we can't deliver, then we might have to transfuse the blood to the baby and keep the baby as much as possible intrauterine. For that only we have to do a codocentesis, so intrauterine transfusion, right? So interperitoneal transfusion also can be done. This is a very easy method than the codocentesis. Here we just take this O negative, CMV negative washed packed cells, cross-matched against maternal blood, and we put it into the fetal peritoneal cavity, and normally it will be absorbed through the small vessels in the baby's tummy. So what we do is, we check if the mother is iso-immunized. If the mother is Rh negative and we know that she is iso-immunized in pregnancy, we check a thing called unexpected antibodies, right? Unexpected antibody titer කියලා එකක් බලනවා. Now that is done every fortnight after 16 weeks. And when it is reaching a critical level, we do a thing called, we do this middle cerebral artery peak systolic velocity or amniotic fluid spectrometry. Either of those two we will do. If the මම එන්න ඇවිල්ලා ඉන්නේ මම ඇයි දැම්ම තම හතරෙන්නේ මම හතරමාර පහන මම සීස් එකක් තියෙන එක කරලා එන්න. So when this unexpected antibody titers are high, the lab will tell, okay, it's a critical level, there's a chance that fetal anemia is there කියලා අපිට lab will tell. If the lab tells like that, we start doing our middle cerebral artery peak systolic velocity or the amniotic fluid spectrometry. And then if that also confirms that the baby has a high chance of anemia, we can do PUBS and do intrauterine blood transfusion, or we can deliver the baby. Either of those, right? Okay, so that is fetal Rh isoimmunization. So I told you a few things. This Rh system. What are other systems that are involved other than the Rh system? And I talked about how can this sensitization can happen. Then I told you how to prevent this sensitization. Then I told you if this sensitization happens, then how would we manage that woman in subsequent pregnancies. Even if that woman is affected, how we can manage as much as possible and deliver the child without much of a problem. Okay, good. I will, if you want this lecture, you can ask from the department. I will give to the department tomorrow or day after. Okay? Any questions? Okay.
Thank you, sir.